So the next talk is about what the neurologist needs to know in choosing the right assay for autoantibody testing. Here are my disclosures. So when you have a patient with a suspected antibody-associated autoimmune encephalitis and you consider to send samples to the laboratory, it is very important for you to know that there are different subgroups of autoimmunity. First, we have autoimmunity associated with antibodies against intracellular neuronal antigens. Second is autoimmunity associated with antibodies against neuronal surface antigens. Third is autoimmunity associated with glial antibodies. And then we have an autoimmunity where we do not find any antibodies at all. This is a very heterogeneous group, and I will talk about this at the end of my talk. I will now start with the autoimmunity with intracellular antibodies. So what we believe here is that the antibodies are only an epiphenomenon because they cannot really reach their antigen because it's intracellularly, and the disease is most likely T-cell mediated. The disorder usually occurs as a paraneoplastic neurological syndrome, and not always, but often the patients only show poor or no response to immunotherapy. What is a paraneoplastic neurological syndrome? So what happens here is that a patient has an underlying cancer and the tumor cells during the course of dedifferentiation suddenly start to express an antigen that under physiological condition can only be found in the brain. And this unphysiological ectopic expression activates the immune system. The immune system recognizes the antigen as foreign and attacks the tumor cells, which is good because it keeps the tumor small. But unfortunately, once activated, the immune system now also attacks the antigen in the brain and causes the neurological problem. And I have scanned here for you the medulla oblongata of a patient who died due to an HU antibody-associated brainstem encephalitis, and we stained the medulla oblongata with antibodies against CD8. And when we zoom here into the olivary nucleus, you can see here an accumulation of T cells that group around neurons and destroy the neurons. And when we stay in the same section with antibodies against microglia, you can see that all over the gray matter, so in the olivary nucleus, but also in the formatio reticularis, you have here these so-called microglial nodules that occur on each side where neurons get irreversibly destroyed. And this explains very well why patients only show this poor or limited response to immunotherapy because of this irreversible damage. HU is only one out of minimum 7 so-called well-characterized onconeuronal antibodies that are all associated with a specific type of tumor, like small cell lung cancer or memory cancer, and a specific neurological syndrome. For example, YO antibodies are usually associated with gynecological tumors or memory cancer and clinically present as a cerebellar degeneration. And I will show you a video now of a 68-year-old female patient with a diagnosis of breast cancer 5 years ago. She was treated with surgery and chemotherapy and was believed to be in remission, but 5 years later she suddenly started with a subacute onset of cerebellar degeneration and went to the doctor. Tumor screening and antibody testing was initiated, and we found YO antibodies, and a recurrence of her memory cancer was found.
Seu nome completo. Thelma Aparecida Ribeiro Dias.
So immunotherapy was immediately started, but she did not respond at all, and the ataxia progressed, and as you can see here in this video, she at the end was wheelchair bound. Another example is this patient here of a 59-year-old female with the diagnosis of breast cancer only 3 months ago, and then she suddenly started with ptosis and double vision, and the disease progressed to a severe brainstem encephalitis. And also here, immunotherapy was immediately started, but the patient did not respond at all. So when you look at these different examples, you may realize how important it is to avoid false positive or false negative results. And therefore, a task force, the PNS Euro Network, recommended the laboratories to always perform 2 different test methods to really confirm the diagnosis. For example, what you can do is that you perform a tissue-based assay. This is a red cerebellum stained with a serum with YO antibodies, labeling very nicely the Purkinje cells. And for example, as a second method, you can perform a line assay here with a recombinant YO protein, staining here with this very nice positive band. So in this situation, it's easy, 2 positive results, and you can sign out here the report with YO antibodies. So what you as a neurologist should know now is that some laboratories, due to different reasons, can only perform 1 test method. And this can be associated with some pitfalls. And I would like to show you 2 examples on that. The first one was the sample of a 25-year-old man with seizures that was sent for antibody testing. And in the first run, I did a line assay. And surprisingly, I found a clearly positive band with YO antibodies. And this does not fit at all because the patient, first of all, is a man, and YO antibodies are associated usually with gynecological tumors and with mammary cancer. And second, the patient presented with seizures, and YO antibodies are associated with cerebellar ataxia. So I did in a second run a tissue-based assay, and this was clearly negative. And so most likely the result of the line assay was unspecific and false positive. But a laboratory who only performs the line assay may sign out a positive result in this situation. And the second example is this case here of a 50-year-old male patient with vertigo that started subacutely and then later progressed to ataxia and dysarthria and nystagmus. And the clinicians suspected a paraneoplastic neurological syndrome and sent the serum for paraneoplastic antibody testing. So in a first step, I did the line assay. And the only thing that I saw here was a really very, very weak band at the level of the TR antibodies, but it was really very faint. So I did in a second step the tissue-based assay, and surprisingly here the Purkinje cells labeled very strongly positive. So the TR antibodies were characterized in 2012 as antibodies directed against delta notch-like epidermal growth factor-related receptors, so DNER. And meanwhile, there are cell-based assays available to test for these antibodies, so I performed the cell-based assay, and this was also strongly positive. So I had 2 independent test methods that confirmed this diagnosis, and I signed out a positive result. But since it was so unusual that the serum resulted in such a faint labeling of the TR antibodies, I asked the neurologists whether they still have some CSF in their archive stored. And indeed they had, so they sent the CSF also for testing. And this was interestingly strongly positive in the line assay. So a major pitfall in this case was that only serum was sent for antibody testing. So based on the antibody results, then the physicians started with a tumor search, and they performed an FDG PET. And indeed, they found a positive lymph node that was biopsied, and a Hodgkin's lymphoma was diagnosed. But despite of the treatment of the Hodgkin's lymphoma and the immunotherapy, the patient did not really improve. And an MRI was performed, and this showed already some atrophy of the cerebellum. So let's now move to the next group of autoimmunity, which is associated with antibodies against neuronal surface antigens. Here we believe that the antibodies directly interact with the antigen because it is on the surface, so the antibodies can reach the antigen. And the characteristic feature of this type of autoimmunity is that patients usually show a very good response to immunotherapy. Meanwhile, we know a large number of antibodies that are directed against surface antigens, and this list is getting longer every year. But one of the first antibodies that have been discovered was the NMDA receptor antibody that is causing the NMDA receptor encephalitis. So what happens in NMDA receptor encephalitis? The patients suddenly start to produce antibodies against an extracellular epitope of the NMDA receptor, and the binding causes a cross-linkage and an internalization of the receptor. So the result is that the neurons have a lower density of NMDA receptors on the surface, and this causes a dysfunction of neurons. But it is important to know for you that it is only a dysfunction and not the destruction of neurons, and this explains why the patients show this good response to immunotherapy. And this is also very well reflected by neuropathology. So when you look into the brain of a patient with NMDA receptor encephalitis, you will find that the neurons are perfectly well preserved. And the only thing that is pathologic is when you stain for inflammatory markers and you go into detail, you will find that there are numerous plasma cells that are grouped around the vessels. And these plasma cells produce the NMDA receptor antibodies that cause the dysfunction of the neurons. And this then presents as the severe neurological syndrome that we know in NMDA receptor encephalitis. But you will hear more about the clinical presentation of NMDA receptor encephalitis later on in the talk by Martin Titulaire. And what I want to show you now are two more examples of surface autoimmunity, just to give you a feeling of how broad the spectrum can be. And the first example is the mGlu1 antibody that is associated with cerebellar ataxia. And I show you videos of a 38-year-old female patient that had a subacute onset of cerebellar ataxia, and when she came to hospital, she had a prominent head titubation that you can see here in this video.
Alessandra, levanta a mão para mim. Levanta a mão. Levanta a mão. Agora a mão esquerda. Levanta a mão esquerda.
In between, she also had some catatonic episodes that you can see here. And a broad differential diagnostic workup was initiated, but unfortunately all results that came back were negative. And since the patient slowly started to improve, the physicians finally decided to send her home. And only 1 year later, she was readmitted to another hospital, and the video that you can see here was made then. So this is 1 year later now.
Vai. Pode voltar.
And what you can see here is that the patient still has a very severe cerebellar ataxia. So in fact, she was wheelchair bound. And at that point, the antibody testing was initiated, and we found mGlu1 antibodies. So based on these findings, an immunotherapy was immediately started, and the patient showed some response, although she already had some cerebellar atrophy in the MRI, and her response was incomplete, so she still has some neurological deficits. And another example that I want to show you is an autoimmunity that does not primarily affect the central nervous system, but the peripheral nervous system. And these are nodal and paranodal antibodies that affect the node of Ronvier. The node of Ronvier has a very complex structure, and a number of adhesion molecules are necessary to keep it in shape. So we have here the neurofascin 155, the contactin 1 and the Caspar-1 that attach the terminal myelin loops of the Schwann cells to the axon and keep the ion channels in the nodal region and enable the saltatory conduction. When you now have an autoimmunity against one of these adhesion molecules, the result is a detachment of the terminal myelin loops, and this ends up in a conduction block and initiates a demyelinating process that clinically presents as an atypical chronic inflammatory demyelinating neuropathy phenotype, sometimes with an acute onset that can be misdiagnosed as a Guillain-Barré syndrome, and in many cases also with severe ataxia and tremor. So some of you will ask now, why is it so important to recognize these patients as specific subtype of CIDP? And this is because the patients often do not sufficiently respond to the classical CIDP treatment, including EVIG, steroids, or plasma exchange. And I can show you a very nice example on that. This is a man who started with an acute onset CIDP with a severe sensomotoric polyneuropathy. And since he did not respond to the treatment, more testing was initiated, including the search for nodal and paranodal antibodies, and we found antibodies against the contactin 1 Caspar-1 complex. And based on these findings, treatment was switched to rituximab, and the patient just a few days ago sent us this video here showing that he really nicely responded to this treatment. So when you see these examples, it is clear that a fast diagnosis is important because patients respond to the proper immunotherapy. And when you consider now to send a sample for surface antibody testing to the laboratory, it is important for you to know that we need different test systems for their detection. And why is this the case? This is because surface antibodies recognize a conformation-dependent epitope, so we need the natural configuration of the protein. And all test methods that cause a denaturation or a digestion of the protein, like for example in the immunoblot or also with a strong fixation of tissue, are not successful to detect these antibodies. There are currently 2 test methods available that are recommended for the detection of surface antibodies. One is the cell-based assay and the other one is the tissue-based assay. The cell-based assay uses a cell culture, usually of HEK cells, but you can also use other cells, and you transfect these cells with the respective plasmid, like for example the NMDA receptor. So the cells start to express this protein, and then you stain it with the serum or the CSF of your patient. And when antibodies are there, they bind to the protein and you can see a positive fluorescence signal. There are commercially available cell-based assays, but for the very recent antibodies that have only been recently discovered, there are only in-house cell-based assays available. The advantage of this test method is that it is highly sensitive and specific. The disadvantage is that you really only test those antibodies that you are asking for. And in a patient with a novel association with a novel clinical syndrome, you may overlook the one or other antibody. And on the other hand, we have the tissue-based assay. Here you take slices of, for example, rat brain, but you can also take a mouse brain, for example. And these rodent brains are very similar to the human brains, and they have all the receptors that also human brains have. And when you stain these sections with serum or CSF of the patient and antibodies are there, they will recognize their antigen and will bind to the brain, and you can visualize that with the brown staining product that you can see here. And with this method, you do not only detect most of the currently known surface antibodies, but also new antibodies that have not been characterized yet. And for further characterization, you can use live neuronal cell cultures in research laboratories to confirm a surface staining and maybe to characterize then the antigen later on with immunoprecipitation. So how can a practical approach for the antibody diagnostics look like? So what I personally prefer is that I first screen with a tissue-based assay. So you can see here me sitting at the microscope having this tissue-based assay of a rat brain stained with the CSF of a patient with NMDA receptor encephalitis. And when you zoom here into detail, you can see a very nice staining of the hippocampus. So when you can see this, you know this patient must have antibodies. And then in a second step, I perform a cell-based assay to confirm the diagnosis. And now I would like to quickly introduce you to the third group of autoimmunity, which is associated with glial antigens. And maybe some of you will ask now, okay, why do I present this here in the antineuronal autoimmune encephalitis? But I would like to show you a case that we recently had in our neuropathology laboratory, which was really extremely interesting. And this was a 67-year-old female patient that first had pneumonia, and then 2 weeks later she suddenly started with a headache and dysarthria and hemiparesis. She called the ambulance herself when she noticed her symptoms to go to hospital, and when she was brought to the emergency room, she suddenly developed a severe epileptic seizure that was only stoppable with barbiturates. And after that, she still was unconscious and was in a very poor condition. So the neurologists immediately made an MRI, and what they found was that she had a severe white matter lesion. So what they did was that they immediately started with steroid therapy because she also had brain edema. But despite of that, she had a rapid progression of her symptoms, and so at some point there was the suspicion that this could be a lymphoma, and a brain biopsy was performed. And this was the point where our laboratory was involved, because the brain biopsy was sent for neuropathological workup. And this is what we received. So several very tiny pieces of white matter. And what we found is that there was some perivenous demyelination. So this is a staining for Luxol fast blue, that myelin sheets are stained blue here, and the lack of the blue staining indicates a demyelination. And when you go into higher magnification, you can see here some macrophages that digest myelin products. So when you look at this, this looks like a classical case of acute disseminated encephalomyelitis, so an ADEM. And the only problem that we had was that the clinicians indicated in their referral sheet that there was a steroid treatment before the biopsy. And this is always a nightmare for neuropathologists, because steroid therapy can melt away lymphoma cells, and you may only see the residual of the lesion. And indeed, what we found were several apoptotic lymphocytes. So this was a really difficult situation in the differential diagnosis to the lymphoma that was suspected. So we asked the neurologists to send us serum and CSF for antibody testing, because we have a biomarker for ADEM, which are the MOG antibodies, so antibodies against myelin oligodendrocyte glycoprotein. And indeed, we found positive antibodies with a titer of 1 to 320. So this confirmed our first suspicion, and so we finally signed out a neuropathological report of ADEM associated with MOG antibodies. So based on our diagnosis, the neurologists initiated a very severe immunotherapy with steroids, plasma exchange, and then rituximab. But despite of that, she progressed, and she finally died due to multi-organ failure. So in this situation, it was very important for us to really confirm the diagnosis that we made in the biopsy. So we asked them to send us the autopsy, the brain autopsy of the patient. And I myself did this autopsy, and you can see here the brain of the patient, and you may already see here in the white matter some lesions, grayish discolorated lesions. And so we were really very curious what we will find in the histological workup now. And so we received the histological stainings then a few days later. And what you can see here again is a Luxol fast blue stain that labels the myelin blue, and everywhere where you have a demyelination, you only have a pink staining. And you can see here the same pattern that we already described in the biopsy specimen with this perivenous demyelination. But when you zoom out, you can see the extent of the lesion. So these perivenous lesions were confluent and formed huge demyelinating plaques here in the white matter that affected both hemispheres and the whole brain, causing here a severe demyelinating disease. And there were also some demyelinating lesions in the cortex, which are most likely responsible for the epileptic seizures that the patients had. And so MOC antibodies, usually what you all know, are normally associated either with a neuromyelitis optica spectrum disorder, very rarely also with multiple sclerosis or with clinically isolated syndrome. And more frequently, MOC antibodies are associated with different types of atypical demyelination that can be monophasic or recurrent. And one very classical presentation is ADEM. And ADEM is one of the most important differential diagnoses to antineuronal autoimmune encephalitis, because it can present in a very similar way with encephalopathy and focal neurological deficits. And recently, and this is also very important in the differential diagnosis to the antineuronal autoimmune encephalitis, is a novel clinical presentation, which is the encephalitis with steroid-responsive seizures that in the MRI only presents with unilateral hyperintense cortical lesions in the flare, but no clear-cut demyelinating lesions. And these patients present typically with seizures, and they are steroid-responsive. And we recently had the chance to look in a large sample of biopsies and also 2 autopsies associated with MOC antibodies. So we specifically looked whether MOC antibodies can cause a cortical pathology. And indeed, in this one autopsy, we found demyelination that was almost exclusively restricted to the cortex. So everything that you see here in orange is demyelination in the cortex, and the green parts is the demyelination in the white matter. And here the same situation. So, and also in many biopsy cases, we saw that MOC antibodies can be associated with cortical demyelination. So this seems to be a prominent feature in MOC spectrum disorders. So what should you know, or what should you consider when you send samples for antibodies testing, so that you do not overlook the intracellular antibodies, the surface antibodies, and the glial antibodies, because they are all important in the differential diagnostic workup. So first of all, the most important thing is that you always send, if somehow possible, serum and CSF for testing, because there are some antibodies that are more prevalent in the CSF, and then we have antibodies that are very well detectable in the serum, like for example MOC antibodies or aquaporin 4 antibodies, although there are also here rare cases where the antibodies are only detectable in the CSF. So always send both to avoid false positive or also false negative results. And then you should know that some antibodies are only detectable with cell-based assays, for example MOC antibodies, because they recognize a human-specific epitope, and tissue-based assays that are based on rodent brains, rat or mouse, fail to detect these antibodies. So if you have the suspicion on MOC antibodies, then please indicate it specifically in the referral sheet. So now we come to the last group, which is the autoimmune encephalitis without detectable antibodies. So many of you will know patients where you have the strong suspicion of autoimmune encephalitis, but no matter in which laboratory you send the sample or whatever you ask for, you will get back a negative result. And this frequently happens with specific neurological syndromes, especially with patients with acute cerebralitis. There are only few patients with mGlu1 antibodies. We have seen this example in the presentation now. Very recently, mGlu2 antibodies have been described, or very rarely glycine receptors antibodies have been described with cerebralitis. Or also brainstem encephalitis is often antibody negative. Only few cases with opsoclonus myoclonus syndrome have intracellular antibodies, RI for example, and very rarely surface antibodies have been described. Glycine receptor, for example, or also very rarely GABA B receptor antibodies, but most patients remain negative. The same is the case with patients with basal ganglia syndromes. And the question now is, do our current test methods simply fail to detect these antibodies? Or are maybe other pathomechanisms involved in causing the disease, as it has been described for narcolepsy or for Rasmussen's encephalitis, for example, where a T-cell mediated mechanism has been discussed? So, in the clinical practice, you may face the situation that you have a patient with suspected autoimmune encephalitis, but antibody test results are either not available yet or they come back negative. And in this situation, we have diagnostic criteria that have been published by Kraus et al. In Lancet Neurology 2016 that will help to make the diagnosis based on clinical criteria. And in this context, I just in conclusion want to show you a little video of a special patient where I, as a neuropathologist, made the diagnosis. So this was a cat that was found with epileptic seizures and was brought to the veterinary doctor, and of course no antibody test results were available, and so the diagnosis was based only on the clinical presentation, and steroid treatment was initiated and the cat responded very well. And this was an example of a cat with LGA1 antibodies. So in summary, onconeuronal and surface antibodies are tested with different assays. In case of unexpected positive or negative results, please discuss these with the laboratory physician, and you can consider to retest or to send for a second opinion. The interpretation of test results should always be done in context with the clinical presentation. The tissue-based assay for surface antibodies can detect most of the currently known surface antibodies. There are only some limitations for MOC and for glycine receptor antibodies that should be directly tested with the cell-based assay. And please indicate the main clinical symptoms in the referral sheet, because this will help the laboratory physician to perform the right assay. And last but not least, please always send serum and CSF for antibody testing to avoid false positive or false negative results. So thank you very much for your attention. Okay. So, hello everybody. I'm now here online. Unfortunately, there were some problems with connecting, but now I'm ready to make the chair here of this session. So first of all, thank you very much to all of you for participating in this teaching course. And we have already heard the first two lectures, so we are already in the middle of this session. And the first talk, as you have seen, was done by Professor Stefan Bittner, who is professor for neuroimmunology in the University of Mainz. And he did his talk on the basics of neuroimmunology. And I saw here some questions to this first talk that I first want to ask to Stefan. Is Stefan online now?
Er ist online, aber antwortet leider nicht.
Okay. So we will see. So I think he's now unmuted. Maybe he can answer now. And if not, then maybe I will go directly to some questions
that were made to my talk. So there was one question concerning what is better to test for specific antibody, serum or CSF. And so I showed one slide to this question. So indeed, it is very important. So what I always recommend is to always send serum and CSF for antibody testing, because there are some antibodies that are more easy to find or more prevalent in the CSF, like for example, NMDA receptor antibodies or AMPA receptor, GABA-B. And then there are some antibodies that can also be found in serum, or more often in the serum, like for example, MOG antibodies that, as you have seen before in my talk, is a very important differential diagnosis to antineuronal autoimmune encephalitis. So MOG antibodies are very important. And also aquaporin 4 antibodies can often easier found in the serum than in the CSF. But since at the beginning you don't know which antibody you have to expect, it's very good to send both serum and CSF. And then we will look more where there are some more lectures on that. So in which conditions do we suspect nodal and paranodal antibodies? So this is a very good question. In general, there are some specific features in peripheral neuropathies where you may consider nodal or paranodal antibodies. And this is especially when you have a patient with an acute onset of a neuropathy that looks like Guillain-Barré syndrome, but that later turns out to be chronic, so that where you switch then the diagnosis to CIDP. And especially when the patients in addition have a severe tremor or ataxia. So in these conditions, in case of a peripheral demyelinating polyneuropathy, you may consider nodal or paranodal antibodies. And then there is an additional feature, and this is when you treat the patient with CIDP with the characteristic treatment like EVIG or steroids or plasma exchange, and your patient simply does not respond, then also in this situation, you may consider to test for paranodal antibodies. And if this turns out to be positive, then you may consider to switch your treatment and to rituximab if steroids and the other treatments did not work.
Mensch?
And I think now is here Stefan Bittner now online. If not, so then I will check once again if there are some more questions to my talk. So if the patient's results are late, so I guess you mean that the antibody testing results come late and the patient clinically deteriorates, continues to deteriorate. So how do you manage the treatment? So in this situation, if you have excluded all other causes for this condition, especially infectious conditions, you may of course consider to start empiric immunotherapy and see whether the patient responds. And so I think these are all questions now that arose from my talk. And so I suggest we may continue now to our next presentation, which will be held by Professor Maria Isabel.